Hello everyone, myself Dr. Vinod Kaushik. On the behalf of IAP India Digital Team, just welcome you all and just wish you all happy World Physiotherapy Day. Today the webinar is conducted by Andhra Pradesh District and I will not take much more time. I will just hand over to our moderator. Please continue with your webinar, ma'am. Thank you.
Okay, thank you, sir. Good evening, everyone. Myself, Dr. Srikana, District Secretary of IITWC, Krishna District. On behalf of IITWC, Krishna District, a warm welcome to you all on the occasion of World Physiotherapy Day. We the IITWC District, Dr. Sumi, or the Dr. District, Dr. Sri Pravina, District Coordinator, Dr. Meena, District Coordinator. APWC is conducting the webinar on the topic of pulmonary fibrosis and physiotherapy. I would like to thank you, Dr. Sanjeev Jain, sir, the president of IIT, and Dr. Ruchi Vashmina, the national head of IITWC, for giving us such wonderful platform. My heartfelt thanks to Dr. Prabha Vinodman, the South Zonal head of IITWC, for supporting us. Now I would like to introduce my state team. First, our state coordinator, Dr. Firdos ma'am, who support us a lot, and then our state joint coordinator, Dr. Srikala ma'am, and sub state coordinator, Dr. Shalini ma'am, Dr. Pallavi ma'am, Dr. Monica, who helped me a lot in conducting the webinar. Now heartful thanks to. Now I would like to invite Dr. Samana Jain ma'am. She did a master's in cardiopulmonary for India and cardiovascular and med disease exercise therapist for Singapore. She is a practicing decade. She is a founder of PMF Health and Skills Academy, HOD of Krishna Hospital, the Clinic International Mumbai, General Secretary Sports and Fitness Training Foundation of India. She is an international to over 100 of decades. Workshops on cardiopulmonary rehabilitation since a decade internationally and nationally. She has interviewed internationally in multiple newspapers and TV channels. She has received a National Pandemic Warriors Award and more than 14 awards in her career. She interviewed as a renowned Indian chest physiotherapist is published in a renowned African newspaper, Daily News and Women. So we welcome her to today's sessions. Thank you, ma'am.
Hello.
Thank you, ma'am. Dr. Samana.
Dr. Pallavi.
Yeah, myself from.
Okay. Hello, everyone. I hope I'm audible and clear.
Yes, ma'am. Audible.
Yeah, yes, you're audible, ma'am.
Okay, so shall we start?
Yes.
Yeah.
Okay. So thank you, everyone, and thank you, Dr. Pravina, for the wonderful introduction. Before going ahead, it's one of the most important day for physiotherapists across the globe. So happy World Physiotherapy Day to each and every physiotherapist who is watching this, who's not watching this, who will be watching this later. To all the patients who have been treated by the wonderful physios around and physios who give hope to a lot of patients and a lot of students who are aspiring to become physiotherapists. So yes, it's a wonderful day and I'm really glad that Indian Association of Physiotherapy has given me an opportunity to interact with so many physios across the India and many other countries who are now live, to be a part of this wonderful day and celebrate it by sharing knowledge, I think, which is the main motive of each and every physiotherapist. So I won't take much of the time by my introduction. I'm Dr. Samana Syed from Mumbai, senior cardiopulmonary physiotherapist, practicing since almost more than 10 years. So before going ahead, I would just like to, there's something that has happened just an hour back when we were discussing about joining the Zoom meeting, which Dr. Pravina has also mentioned just now. So I just got my interview featured in the African newspaper in Tanzania as a Indian chest physiotherapist. So before going ahead, I would love to share it with you all because I can't hold my excitement. And it's the hard work of over a decade that opportunities like this comes in front of us. So I'll be sharing my screen for PPT. Let me know if you all can see it. Is my screen visible to all of you?
No, ma'am, not visible, ma'am.
Not yet. Okay,
Yes, not at all.
just a moment. Yeah. Is it now? Is it
Yes,
visible?
ma'am. Yes, ma'am. It's already visible, ma'am.
Okay. So before going ahead, yes, our today's topic is pulmonary fibrosis and physiotherapy. And without taking much of your time, I would like to share this with you all because I can't hold my excitement. As I said, I've been featured on Tanzania Women's Magazine, and on the front page of Sunday News, you can get the link, and I'll be sharing the post soon. So yes, IAP Live has been lucky for me, and once again, before going ahead, I would thank Dr. Ruchi Vashne ma'am, Dr. Sanjeev Jha sir, Dr. Vinod Kumar Kaushik sir, and entire team of IAP for giving me this opportunity. So now we would start with the most important topic, which is something that every physio should know for two reasons. One is because before this pandemic, pulmonary fibrosis, the load of pulmonary fibrosis disease was almost 1%, or you can say just 5% of what we are seeing now. And most common disease was mainly obstructive conditions like COPD, asthma, bronchiectasis. But after the pandemic, the load of pulmonary fibrosis globally has increased much more than what it was before. So basically, when we used to talk about handling the pandemic and all the posh that has happened, it was because the world was not prepared for such amount of pulmonary fibrosis cases that we got. And the second reason of me choosing this topic is that September is known as a pulmonary fibrosis awareness month. And since it's also a World Physiotherapy month, so I think it's the best opportunity to actually spread something that we can do. So going ahead with it, when we talk about pulmonary fibrosis is what? If once we understand the condition, then it becomes very easy for us to actually treat the condition. And pulmonary fibrosis is one such condition where physiotherapy plays an important role for improving the quality of life of the patient, to making the patient feel less breathless, to improve the daily activities of the patient. And that's why for every physiotherapist, I believe it's very important to know their role in the pulmonary fibrotic cases. So when we talk about pulmonary fibrosis is a lung disease that occurs when the tissue is damaged and scarred. Well, you must have heard of some term like pulmonary fibrosis, interstitial lung disease, and few terms like idiopathic pulmonary fibrosis. Well, all those who are attending this course, attending this lecture, they all can put their questions, which we'll be taking at the end. And I would love to clear all your doubts, and we would be taking out some time to interact as well with you all at the end, so that nothing is missed. So coming back to pulmonary fibrosis, so it's a progressive lung disease. Idiopathic pulmonary fibrosis is a term where the known cause of fibrosis is not there. Like, we don't know the exact cause of what caused fibrosis in that patient. So those cases are called as idiopathic pulmonary fibrosis, and which is progressive in nature. Maybe initially the patient may not get symptom, but as the disease progresses, then the patient starts getting the symptom of pulmonary fibrosis, which we will be discussing ahead. And when we talk about PF is a condition where we know the known cause, that is interstitial pulmonary fibrosis, or any known cause which has caused pulmonary fibrosis. For example, the commonest one which we can take is COVID-19, the ARDS, which was caused with the progressive COVID-19 infection that led to pulmonary fibrosis, and that was the kind of PF that we are talking about. So hope that clears it out. So when we talk about pulmonary fibrosis, this is how your lung looks like. Now, how this happens, if you would see the structure over here, Now, I won't take much of the time just to explain you a bit about it. When we talk about lungs, definitely we know this trachea, which gets divided into primary, secondary bronchus, and which gets divided into terminal bronchioles, and then you see this alveoli. So basically, alveoli is the air sac. When we breathe in air, the air goes inside, all the gaseous exchange happens in the alveoli, it expands, it helps in expanding the lungs, and that's how a normal breathing mechanism takes place. So any kind of condition that leads to scarring of the alveoli or inflammation or any damage to the alveoli hampers your oxygenation in the body. It hampers the gaseous exchange. So basically, in a very simple term and in a very layman language, the alveoli is responsible for gas exchange. They move oxygen to the capillaries and pick up the carbon dioxide from the blood to the breathe out. So due to scarring of the lung tissue, this process cannot be carried properly. And this leads to the main symptom of pulmonary fibrosis, that is breathlessness. And second symptom as dry cough. So yes, reduced oxygenation, reduced saturation, breathlessness are the commonest symptom that we see in pulmonary fibrosis cases. And in most of the pulmonary fibrosis, you will always find dry cough, but there are some cases where you can also get some kind of productive cough and secretions in these patients also. Now, if you must have heard, just imagine a COPD patient got COVID-19. So definitely, if his lung is going into fibrosis, the patient who already had secretions goes into fibrosis. So definitely there will be secretions and there will be the fibrosis as well. So that's why it is the program as a physiotherapist that we design is very individualistic for every patient. So going ahead, when we talk about the pulmonary fibrosis, this is how your lung looks like. And this is what we call as honeycomb structure. I will show you an X-ray to actually give you a better presentation of actually how your pulmonary fibrosis lungs look like. So pulmonary fibrosis is considered as one of the restrictive condition where if you would see the size of the lung is reduced as compared to what normally it is, which looks like this. So now if you could see this is a normal lung and this is a restrictive lung. Because of the scarring of the tissue, because of any condition that has led to the inflammation and then followed by scarring of the tissues, that makes like what you can say, the lung keeps on reducing in size because also because of the alveolar damage that has happened, and also it restricts the expansion of the lung. So in short, the lung loses its elasticity, and that gives us the first base of our treatment. Elasticity is reduced. Our work as a physiotherapist is to expand the lung. Elasticity is reduced. That means the breathing capacity of the patient has been reduced, and we have to start working on that. Alveoli is damaged, so oxygen is reduced, and as a physiotherapist, we have to help the patient to do his daily activities with the oxygen content and the amount of oxygen that can be given as on a supplemental base. And that's how we'll design the program. So as we go ahead, you yourself will be able to understand what our role is, and I will try to simplify it as much as possible. So coming back to this, when we talk about restricted condition, if you could see over here, when we talk about any kind of restricted disease, the forced vital capacity of the lung is reduced. If you can, that you can actually make out from the size itself, what it is shown over here. Total lung capacity reduces, residual volume of the lung reduces, forced expiratory volume can reduce or cannot reduce. So basically it depends entirely on the case. Definitely when the lung expansion is affected, it's not just the inspiration that is affected, it's the expiration as well that will be affected. So fourth point as a physio that you need to understand is when you have any kind of such condition, you have to focus on both the inspiratory and expiratory mechanism and exercises and strengthening of the patient. So going ahead, once again, if you would see over here, the lower part, this is called as the honeycomb structure, scarring of the lungs or fibrotic patches that we see in any kind of interstitial lung disease. So I would try to give you the overview as much as possible of this condition. Now, when we talk about PF, how do we get it? So there are actually more than 200 known cases of pulmonary fibrosis, which is non-idiopathic, because as I said, idiopathic is all about when you don't know the cause. So the commonest one are mentioned over here. This is for the reference, any kind of ARDS. As I said, what we got in COVID-19. So COVID-19 disease, let's just talk briefly about it. So COVID-19 condition was such in which your lung was prone to pneumonia. As the pneumonia used to increase because of the cytokine storm, chemokine storm, the pro-inflammatory products that kept on increasing inside your lung, it led to more and more damage of the lung, leading it to acute respiratory distress syndrome or respiratory failure. And as the lung heals from that, it covers the lung in the form of, or for example, the lung gets scarred. That's how actually the ARDS heals. So basically, the future of ARDS is actually a scarred lung or scarring of lung. Now, this scarring can be, if it's not ARDS, this scarring can be on the entire lung or on the lobes of the lung or certain parts of the alveoli. Everything depends on the severity of the cases. So that is one of the reasons how you can get IPF. Then you can, the occupational disease, the commonest thing that we know about pulmonary fibrosis is inhaling any substance like coal, silica, progressive massive fibrosis, asbestos. This can lead to conditions like interstitial lung disease that ultimately leads to pulmonary fibrosis. There is something also called as radiation-induced pulmonary fibrosis. Well, yes, with any kind of radiation or repeated exposure to radiation, your lung can go into fibrosis as a reaction. Congenital condition like cystic fibrosis, the commonest one in pediatrics, and this is one of the commonest patient crowd that we get in our pulmonary rehab setup. Autoimmune conditions, connective tissue disorder, granulomatous conditions like sarcoidosis, TB tuberculosis is again a pulmonary case of pulmonary fibrosis, and aging. So if you will take the X-ray of any 70-year-old lady or female, you may find sometime that their lungs have shrunken in size, and sometimes there is also fibrosis in the lungs, which is asymptomatic. So we do get a lot of patients where when we see the X-ray looks like a fibrotic lung, but the patient is absolutely fine with 90-92 of oxygen, which is actually very much normal. This oxygen saturation is very much normal for our pulmonary fibrosis cases. So up to 92, we consider it as absolutely normal. They're able to do their activities as well, and the symptoms are really not that aggravated unless they do any aggressive activity that reduces their oxygen up to 88 and it comes back to 92. So this is some of the commonest case that we have been dealing with in geriatrics. So yes, that's why we have also included this. So when we come to symptom, the symptoms are similar to most of the respiratory conditions. That is definitely the main symptom is breathlessness, and breathlessness is something that makes it really difficult for a pulmonary fibrosis patient to survive. And yes, because of that, our main role enhances in this as reducing the breathlessness, and that's what we are supposed to do. Unproductive cough that is persistent, and as I said, there are chances if the patient has got mixed kind of condition or any other previous condition, there may be some cases which may have secretions, but usually pulmonary fibrosis symptomatically shows reduced dry cough or unproductive cough. Shortness of breath, especially while the patient is engaged in any activities. Greater levels of fatigue. Now, this is the most common symptom if you would have seen COVID-19 conditions who are severely affected or severe COVID-19 conditions, the strength and endurance of every patient was reduced. And we have been working for making their strength improved and endurance improved for like six months of gap. So yes, in any kind of pulmonary fibrosis, or you can say generally in any kind of restrictive condition, the strength and endurance of the patient is reduced significantly, and that leads to greater and greater levels of fatigue. Low-grade fever is also common in such cases. Muscular pain, joint pain, unexplained weight loss because of the hypoxemia. One of the reasons of weight loss is that as well. Clubbing in fingers and toes. So going ahead with this, I hope this much is clear, like how pulmonary fibrosis can affect an individual and what all conditions usually come under pulmonary fibrosis. So when we talk about any kind of pulmonary fibrosis, these are the symptoms you have to take care of and the conditions through which we got it, like COVID-19, pneumoconiosis, sarcoidosis, any kind of occupational disease, smoking, or whatever we have mentioned before. We have to concentrate on that and then plan the assessment and then the treatment of the patient. So when we talk about treatment, what exactly we should be focusing on a case who has got pulmonary fibrosis. Now, don't read that. I want you to first listen to me so that we can just go ahead with it. So now I said that breathlessness is something very common. Second thing, I said that the patient is having low oxygenation. That means that our two main criteria should be, first, reducing the work of breathing, and second, improving the quality of life of the patient. So definitely we have to plan such kind of activities that helps the patient to conserve their energy, and that is the main primary thing that you should focus whenever you design a pulmonary rehabilitation program or a physiotherapy program for any kind of pulmonary fibrosis condition. So yes, the first thing is energy conservation technique. So whatever you design, you should pace the activities. Activity pacing is the primary key of designing a pulmonary rehab condition for any kind of fibrotic cases. So basically, why we do all this? Quickly, just going through it, then we will discuss more about the treatment. Maximize the patient's quality of life, educate the patient about PF, how it can affect their daily life, how they can pace the activity, conserve their energy, use oxygen supply whenever required, how much oxygen is normal for them, how much is not normal for them, how to cease smoking, everything, providing the methods of actually improving their alveolar ventilation, lung volumes and capacities, reduce the work of breathing, maximize aerobic capacity, optimize physical endurance and exercise capacity, and general muscle strength, thereby peripheral oxygen extraction. Now, why peripheral oxygen extraction? Because definitely if there is imbalance of oxygen in your body, definitely your lungs will take up all the oxygens from the periphery, your muscles, and that will lead to hypoxia, muscular strength reduction, myopathy, polyneuropathy, and a lot of other conditions. So you have to focus on everything and not just the lungs of a patient whenever you design any kind of pulmonary rehabilitation protocol for such conditions. So basically, let's start with the treatment part. First thing, if you could see, is of course educate the patient. We have really spoken about it. Second important thing, you should know that whenever you will give any exercise to the patient, the oxygen of that patient will fall. And this is very, very, very normal in any kind of pulmonary fibrotic cases. And you are not supposed to stop your treatment with that. Now you will say that why she's saying not to stop the treatment if the patient's oxygen is falling, and if I continue to give any kind of treatment to the patient, then definitely the patient will collapse. Exactly. That's the point. That is actually the point. So yes, when you have any kind of pulmonary fibrotic case, what you have to do is, if you see the oxygen of your patient is falling below 88, stop your activity, give enough time for the patient to recover, like 1 minute, 2 minutes, or 3 minutes, and then you can restart your activity. If the oxygenation is not coming up, then please put the patient on oxygen supply. For safer side, if your patient's oxygen is coming down to 90, you can always give 1 liter of oxygen to just add up to your oxygen capacity of the patient. So if you will stop because of the reduced oxygenation in any kind of pulmonary fibrosis case, you would never be able to gain the progress that you are planning to get from such kind of patients. So never stop due to the desaturation of your patient. Rather, what you have to do is focus to have something around for oxygen supply, keep a track of their oxygen supply, give an additional oxygen unit to them so that we can continue the exercise, and then train the patients. And that's how you will help in improving the strength, endurance, aerobic capacity, and all that we have been talking about of the patient. I hope that's clear. Now, when we talk about further, of course, the breathing exercises, the commonest breathing exercise that we use are also very important. And there are many other advanced breathing exercises that we also give to the patient to improve their lung volumes, their capacities, because that is what we have to do. We have to improve the lung volume of these patients. So when we talk about breathing capacity, let me tell you again, this is your lung. If you all can see my hand instead of the PPT, that would be better. Now, basically, this is your lung. This is what happens in your restrictive condition. And now when you have fibrosis, that means if this is your normal expansion and recoil of the lung, now your lung is not able to expand, and simultaneously the lung is not able to recoil because your lung has lost the elasticity. So now your work is to do this and this of the lung. So definitely this will happen with a good amount of and a proper designed thoracic expansion exercises, diaphragmatic breathing exercise, segmental expansion, incentive spirometer. You can look over here. We have two kinds of spirometers which we use. One is usually flow meter, where you have 3 balls and it goes up to 1200 cc, where you can ask your patient to go up and hold it. Of course, I'm sure everyone knows this, and I'm not going to really take your time for this. But you have another kind of meter as well, which is called as lung volume meter. If you would see over here, where your lung volume capacity can go up to 5,000, and you have a yellow best, better, and good marker over there. So here we try to improve the volume of the patient and ask them to hold it, so that once we attain a good flow, we can focus on increasing the volume of the patient. So you have to be very decisive when you decide which spirometer to give to your patient, whether volume or flow rate. It entirely depends on your assessment as well. So don't think that you can just order any spirometer and give it to your patient and tell them start doing it. You can be actually be very precise about it. So going ahead with this, chest mobility exercise, thoracic expansion, strength and endurance. So I will show you some of what we usually do. Pacing and energy conservation technique. As I said, for your entire program should be designed accordingly in such a way that you're able to pace the activity. And that is the key. 1 minute exercise karaya. If you did 1 minute of exercise, the patient is not coming up. If the patient is desaturating, wait for 1 minute, 2 minutes, let the patient settle completely and restart. How we go to gym and do the exercises, right? When we do any kind of muscular training, right? How we do? We don't allow our vitals to come to the baseline, right? We don't allow our heart rate to come back to normal, or BP to come back to normal, or respiratory rate to come back to normal. It's exactly the opposite when we treat any kind of pulmonary fibrosis condition. We allow them to come to the baseline. We allow their heart rate to come back to complete normal, RR to come back to complete normal, and then we restart. And that's how you get maximum amount of benefit in such kind of patients. So then you have pacing and energy conservation technique, as I said, an ergonomic assessment. Check what is there in their lifestyle that is actually consuming a lot of oxygen. Like suppose if something is kept higher above, like higher above their head, where they have to actually go raise their hand, pick it up for 10 counts in a day. Try to make it at the lower level. Why? Because the more you use your upper arm, definitely you will be fatiguing your respiratory system as well. So if you make it lower, it will be easier for a person to do that. Such small kind of ergonomic changes in the patient life can actually conserve a lot of energy and oxygen in these kind of patients. Okay, I hope it's clear till now. So basically, when we talk about thoracic expansion, thoracic mobility, along with your breathing exercises, your thoracic mobility is important, because you don't have to just expand the lungs, you have to work on the muscles as well to increase and improve the aerobic fitness of your patient. Now, this is some of the snippets that we do, thoracic expansion exercises. Now, if you can see a patient over here with the oxygen cylinder. This is how we usually train the pulmonary fibrosis cases. With the oxygenation, we help in maintaining, we don't focus on the continuous flow of continuous desaturation in these cases. We time our program, we design a program, and we allow our patients to go for strength and endurance training with dumbbells, with TheraBands, with aerobic exercise ergometer, and a lot of other equipments that we use for strengthening and aerobic endurance. If suppose the patient is unable to do it by yourself, we have a lot of methods like PNF of respiration and many other 20-30 techniques that I usually teach in my workshops as well, to improve passively the thoracic mobility and expansion of our patients, who can gradually see the result and improvement in their breathlessness. And it is proven. A lot of my students, a lot of my patients have followed it, and they have shown amazing results. So basically, strength, endurance, thoracic expansion, thoracic mobility, lower limb activity, upper limb activity, everything is a key for improving the cardiorespiratory fitness. So it can be your circle cycle ergometer, give it to a patient, ask the patient to do it with oxygenation. Any kind of activity that you can time up with the daily activity of the patient can help you to gain the maximum gain. Now, basically, of course, we don't have too much of time, and pulmonary fibrosis is a huge topic. That's why I am just giving you the overview of this condition, so that we can, at least you can now, when you go to a patient, and whenever we are seeing any kind of patient, we know that okay, oxygen will drop, so that is normal. Allow the patient to sit, give oxygen supply. Second, what you would have learned from it, breathlessness is something we have to work on. So yes, measure the breathlessness through Borg scale, RP scale, work on the exercise of breathing. Teach relaxation techniques to the patient, like a very simple relaxation technique. If your patient is breathless, ask the patient to just go ahead, bend your neck, or release any technique that actually, or just lean back on the wall, any technique that actually releases your diaphragmatic exertion. Third thing, since the patient has got dry cough, teach techniques for again making the patient comfortable while doing any kind of exercises, because we have observed that when these patients try to do any kind of breathing exercises, they cannot do it because of continuous coughing, and that actually increases their fatigue, and that leads to again reduced performance. So all these things you have to consider. In future, if we get more time to actually discuss each and every treatment and technique, we would be definitely doing it. But for now, it's very important for you all to understand the protocol of how we do it. There are a lot of exercises that we give to the patient. Let me just explain you a simple thing, a breath hold technique. I'll just put this off so that we can discuss now. Okay, you can follow me over here. I'm stopping the share. I hope you all can see me, right? So basically, what we do is we give a lot of breathing exercise techniques. Now there are techniques where we try to increase the lung volume of the patient. Why? Because we need this expansion, as I said, right? So for these expansion and all, we modify the techniques in such a way that the patient is able to breathe in more. For example, a very basic, I'm talking about the most basic one, is a breath hold technique. You give diaphragmatic breathing exercise with breath holds. You give segmental expansion with breath holds. So that's how you can design to improve the expansion. Along with it, definitely you can give spirometer, as I said, with expiration, and opposite karke how we do is inspiration. These are all basic techniques, but there are a lot of advanced techniques as well, where you can modify the exercises of the patient by improving the volumes of the patient. And also you can facilitate the muscle, facilitate the ventilatory muscles of the patient as well to stimulate it again. And in future, if we get time, then definitely we will be talking about that as well. So I hope it's better that we take some queries, so that, like, if there is something missed out, we can discuss it through the question and answers, because that's what I think is more important. So I hope you all understood about it. At least you got a gist of it. Definitely we need more time. It's a big disease, and after COVID-19 specifically, let me tell you this, after COVID-19, it's one of the biggest disease, because the amount of COVID patients we have seen, and the amount of pulmonary rehabilitation cases in pulmonary fibrosis we have seen in last 3 years in our setup is beyond our expectation. And we have patients whom we are treating for pulmonary fibrosis for 6 months, for 1 year, and still they are coming to us for actually improving their aerobic capacity, strength, and endurance. So that is the significance of physiotherapists in these cases. And that's why it's important for you to know the importance of physiotherapy in pulmonary fibrotic conditions. So I hope it was clear, and we can take some questions.
Thank you so much, ma'am. So participants, if you have any queries, you can put your questions in the chat box so that ma'am will tell you in detail.
Is there any question? Okay.
Any questions? You can raise your hand and you can send through chat so that ma'am will see and help you out to clarify your questions.
Can you show how X-ray looks in PF? Yes, definitely. I have the X-ray which I have shown you that we have of interstitial disease. I'll just share this screen once again. Okay. Yes. You can see it. Okay. Definitely, you should know the X-ray when you see this, so that to understand it. But just for your reference, if you could see this. Basically, what happens is whenever you have pulmonary fibrosis, we call it as a gravitational traction that happens. So if you would see this patches, like if you can see the border of the lung is distorted. This is the, can you all see? Yeah. This is the lining of the heart, which is again distorted because of the fibrosis. And if you can see the down area, these are the patches. And this is what we call as honeycomb kind of structure, where you can see the fibrosis in the alveoli. Fine. So this is basically how the X-ray in short of conditions look like in restrictive conditions. And just the lung usually looks shorter in size, like smaller in size. So if you can see the lung, the hemidiaphragm is lost, the cardiac angles, the costophrenic angles, everything you see is lost, and the lung looks more reduced in size. I hope that clears it all. We have another question. How much oxygen to give? So now, yes, it's a very good question. It's a very good question. I hope that is clear with the X-ray part. So about the oxygen part, usually when we make the patient do exercise up to 92% of saturation we consider as normal in any kind of pulmonary fibrotic cases. And you can go up to 90 as well if the patient is not getting any symptoms of breathlessness. Fine. But if your patient goes below 88, then you have to stop and you can add on to the requirements of the patient. Now, it entirely depends on the patient. Usually, for patients who are stable, 2 to 4 liters of oxygen really works for them to bring them up to 92. But in cases where there is severe pulmonary fibrosis, even when the patient gets up from the lying down position, or even when the patient starts eating, or when the patient is just, like constipated, or the patient is coughing, the oxygen drops up to 70. So in those cases, usually we give up to 8 to 10 liters of oxygen as well. So it all depends on the condition of the patient, and activity related desaturation is very common. If you would hear about the pulmonary fibrosis cases, there are incidences where the patient just went to the washroom and died because of the pressure they have applied and the sudden desaturation that happened. So it entirely depends on the patient. So restrictive condition disease like pulmonary fibrosis is different from obstructive condition. In obstructive cases like COPD and all, we have a limit of supplying the oxygen as per the condition, which is not there in restrictive condition. It entirely depends on the amount of fibrosis that has happened in the lungs. If patient SpO2 is 82 saturation, can you suggest spirometer? Please suggest spirometer to that patient. If the patient is 82 and on supplemental oxygen, like I have a current case where the patient is having 79% of oxygen off O2 and with O2 up to 90, fibrotic case, post-COVID case, severe ILD, everything, diabetes, hypertension, everything. And I would be putting that video sometime in future with the consent of the patient, if the patient allows me. It's like an everyday sight for us actually while treating pulmonary fibrosis cases. Immediately with spirometer, the oxygen goes from 80 to 83 without oxygen support to 90. And then definitely it comes back. So that's what the power of spirometer is when it comes to pulmonary fibrotic conditions. If your patient is stable, if your patient is on oxygen support, and if the patient is having 82 oxygenation, please give spirometer to your patient. Don't force your patient to go and improve the performance. Allow the patient to increase the flow up to their own limit. So if you see this flow spirometer, this is what a patient can do. Fibrotic cases. So allow your patient to do that, and then ask your patient that gradually now after 5 counts, take a rest and now try for the second one, now try for the third one. You have to be very, very, very patient when you plan to treat any kind of fibrotic conditions. That's why the time limit of patients for fibrosis is usually kept up to 60 to 90 minutes, not because we are giving 90 minutes of exercise to that patient, because we are giving adequate rest in between to that patient. I hope that clear. Okay, anyone else? Is pulmonary fibrosis reversible? If yes, then how chest physiotherapy helps? Pulmonary fibrosis is not reversible, and there was a debate as well in the cases like in COVID conditions. Pulmonary fibrosis in the initial stages got reversed. Basically, it all depends on the time you diagnose the pulmonary fibrosis. There are antifibrotic drugs that you can take like Cofenex and many other are there in the market, which you can take to actually prevent the further progression of the fibrosis. So basically, pulmonary fibrosis is not reversible, but you can control it. And yes, you can help in the expansion that allows in better gaseous exchange, that allows in better expansion of the patient's lung, and that gradually improves the oxygenation of the patient. So that's how physiotherapy helps. You are helping the musculature, the respiratory musculature to work. You are helping the patient's lung to expand. You are helping the patient normalize, of course, not completely, but a bit of the gaseous exchange, V by Q mismatch with better positioning and everything. And that's why physiotherapy is a key, or is of key important in these kind of conditions. Okay, anything? I'm sorry for the video quality because of the monsoon and the burst rain over here. This is what is happening. Is any other question? If you can get, please put down your question. Thank you for all my students who are messaging. Salman, Aarti. Can you show PNF tech for PF? Well, see, for PNF, you need to definitely, I can show you that, but I don't think so here it would be that much appropriate. In future, we will be putting up more courses and lectures with the IEP as well, where we will be teaching PNF techniques as well. And you can surely attend that, because it's not just one technique that I teach. There are 20-30 techniques that we teach our students, which can really help you to actually get a very good performance and outcome of your patient. So I hope I have cleared all the doubts, most of the doubts.
Excuse me, ma'am. Ma'am, I would like to know the differential diagnosis for pulmonary fibrosis condition, ma'am.
So differential diagnosis, see, for pulmonary fibrosis, basically, now, if you know, as I said, obstructive and restrictive, right? So restrictive condition is a kind of pulmonary fibrosis. So you need to understand the restriction is because of the fibrotic changes or because of any other restriction. Now, for that, you need to go in detail with the restrictive disease. Now, restrictive disease can be intrinsic or extrinsic. So extrinsic is anything like from outside, if you are getting a restriction, like obesity. So now it's a very simple example. If you have obesity, the diaphragm is lifted up, your lung reduces in size gradually, and lung cannot expand. So that is restriction, but not fibrosis. So in fibrosis, there is alveolar scarring that reduces the size of your lung gradually, and that then inhibits your expansion. So when it comes to differential diagnosis, the other kinds of restrictive condition is something that can that you have to diagnose properly, like pneumonia. Like pneumonia initially is not a pulmonary fibrotic condition. As it advances, it leads to ARDS. ARDS leads to pulmonary fibrosis in the entire lung. As how it gets better, the scarring of the lung, and that is a kind of PF. So pneumonia is a restrictive condition, but not a PF. Got it? So similarly, there are a number of conditions that you can actually misdiagnose as PF. So PF is something that is intrinsic and comes with the alveolar damage. X-ray is very important to know the exact diagnosis of whether the patient is going into fibrosis or not. Don't get confused with just consolidation, ground glass opacities that you see in COVID as fibrosis. Now, one more example, since we are having lack of time, but I would really like to explain this. Like in initial COVID, if you would see in CT scan, you see ground glass opacities. Okay. Now that is again a kind of less progressive consolidation where the gaseous exchange happens. But as the disease progresses, those areas goes into fibrotic patches. So that is then pulmonary fibrosis, not the initial stage of it. So I hope it clears your doubt.
Yes, ma'am.
I think we have taken up all the questions.
Yes.
If anything else is there, you can approach me on my social media handles, and I will surely try my best to clear your doubts. And if you have any difficulty in planning a treatment protocol for the patient of PF, then I'm always there to help. So thank you once again to all the lovely participants. I loved your questions, and all the organizers. Dr. Surbhi Badoria is not with us. She is the one who invited me, and she's unwell. So let's pray for her good health. And Dr. Hingvi, Pallavi, Pravina, the entire IAP team, Dr. Ruchi Vaishnav ma'am, Sanjeev sir, again Dr. Vinod Kumar Kaushik, and the entire IAP team of Bombay. Thank you, all of you, once again. And
Thank you so much, ma'am.
Thank you so much.
To Doctors Samana, Syed, ma'am, for giving your valuable time on the occasion of World Physiotherapy Day. You have given a very good information regarding pulmonary fibrosis and physiotherapy, ma'am. It will be more helpful for our participants also, and you have taken very rare topic which is more informative. Thank you so much, ma'am, once again. And thank you so much to our IAP President, Dr. Sanjeev sir, for supporting and encouraging us to conduct webinars, sir.
Thank you so much once again. Thank you, ma'am. Thank you, Ruchi, ma'am, National Head, for mentoring and guiding us in every aspect of this webinar. Thank you so much to our South Zonal Head, Dr. Jayaprabha, ma'am, to chair and energize our team. Ma'am, thank you so much again. Thank you to our state coordinator, Dr. Firdos, ma'am, to comfort and encourage us in all the aspects. Thank you so much to our joint coordinator, Dr. Shrikala, ma'am, for supporting and inspiring us. And special thanks to our technical team, Dr. Vinod sir, Uttara ma'am, for assisting and streamlining our webinar in social media. Thank you once again for social support, sir. Thank you, Surabhi ma'am. Even though she is not with us, she's hospitalized. She helped us a lot. And thank you to Pallavi ma'am for selfless support and guiding us for conducting webinar in a proper way. Thank you, Meena ma'am, and thank you, Sri Pravina. And thank you to all the coordinators and sub-coordinators for promoting this webinar and make this webinar success. And thank you all the participants who participated in this webinar. Hope this webinar is very useful for you. Thank you so much.
Thank you.
Thank you, ma'am. Thank you once again. So, hello. Hope everyone enjoyed this session. Thank you so much.
Thank you, ma'am.
Yes, ma. Thank you. Thank you.
Thank you, Pallavi ma'am.
Take care.
Okay, ma'am. Bye, ma'am. See you.
Bye.
Thank you, Vinod sir.